Today, Dr. Kevin Churchwell will discuss the importance of systematic and continuous improvement in healthcare. Boston Children's Hospital is the nation's foremost independent pediatric hospital and the world's leading center of pediatric medical and health research. Kevin has been one of the driving forces behind improving the effectiveness and efficacy of the care provided at Boston Children's while striving to reduce the cost of care.
Kevin is Boston Children's Hospital's first Executive Vice President of Health Affairs and Chief Operating Officer. He's responsible for leading clinical and operating functions across the enterprise. His innovative thinking, solid business acumen, and superb clinical and academic leadership are key to success working collaboratively with clinicians, researchers, and staff members to build upon Children's strong tradition of clinical excellence. He's a graduate of Massachusetts Institute of Technology and Vanderbilt Medical School. Please join us in welcoming Dr. Kevin Churchwell.
Well, thank you. It's a pleasure to be here today. All the presentations you just heard, it just gives you an indication of the activity in the healthcare environment. A lot of people are thinking about what's going on, what we should be doing, and that's going to keep going. I think in the next 5, 10, 20 years, there's just going to be more and more activity because we've got to get this figured out. And the incredible activity, knowledge, innovation that you heard is what we should be doing. So I was just really impressed with that group. It's going backwards. In the early 2000s at Boston Children's Hospital, we had a death. The death was a truly what we call a sentinel event that shouldn't have happened. And it really shook us to our core at Boston Children's. Through the work of and help of state regulators, federal regulators, we really did a deep dive into our quality and safety program and determined that we had to make a significant change. That change involved really putting in place what we believe is one of the leading pediatric quality and safety programs in the country. And I think we've been recognized for that. The recognition is, as you can see in this slide, from many different groups. Just two examples from the Leapfrog group. The Leapfrog group was developed by corporations who have a lot of employees, and they pay a lot for their health insurance, and really work to determine what's best quality. What were they getting for their money? So they created a criteria and a survey and a judgment across many healthcare organizations, adult centers, pediatric centers. We've been recognized by the Leapfrog Group for multiple years in terms of being a top children's hospital in terms of quality and safety. Another example is U.S. News & World Report. U.S. News & World Report, as you probably know, they do work every year determining best hospitals across the country, both adult and pediatric. Out of the 13 years they've been doing it, we've been recognized as the #1 children's hospital in 12 of them. And that's across a spectrum of clinical programs, quality and safety, and innovation. So, we've been doing a pretty good job. We're very proud of the work that we have been doing in the space of quality and safety in pediatrics. But as we sit down as a senior leadership group, we have begun to realize, and we realize that there's much more work to do. The bar in terms of quality and safety that our patients and families expect of us continues to rise. And we've been thinking about how to really get to that next level of quality and safety. And our thoughts have been around how do we embed quality and safety in everything that we do. In our clinical programs, what we do at the bedside, how we think about our facilities and how we build them, how we interact with our patients and families, how do we keep safety and quality at the forefront in thinking about those interactions and development of processes. So the next few slides, I'm going to go through what our thinking is, what we're thinking about now and what we're executing on those three different spaces. First, we call it building a high reliability culture, and that's really the work at the bedside, our clinical programs, the care at the bedside. So, as I said, we've been recognized for our work in quality and safety, and I'm very proud of that. But we did a snapshot. We took a snapshot and asked the question, are we harming patients? This is just a 2-year look. These names are not the names of our patients. We changed the names to protect the innocent. But what's beneath them in terms of what happened is true. This is a slide that describes harm that has happened at our children's hospital. We define harm as an outcome that we did not expect, that was related to a deviation in our normal processes. I will tell you in this 2-year period that we looked, at least one of these patients, one of our children, died because of our deviation from process of what we do every day. Sandy Fenwick, who's the president and CEO of Boston Children's, and myself look at this slide, and we describe that it haunts us. We look at this and we ask the question, what could we have done differently to change the outcomes? So we've decided that our goal should be that this slide should be a blank slide. We should get to 0 preventable harm in our hospital. Well, how are we going to get there? Well, there's been a lot of work, not just in healthcare, but across multiple industries, to look at how do you get to 0 likelihood of bad outcome. We call it 0 harm in healthcare. There's been work that's looked at the nuclear power industry as an example. How do you prevent any instance that might occur? Because any instance that might occur could lead to a catastrophic problem. Commercial aviation is another example where there's been a lot of work, as you can imagine, since the 1970s to reduce the incidence of accident. And you can see flying is one of the safest industries or safest things you can do because of that. The military, in terms of aircraft carriers and how they fly all the time in terms of those jets. They've looked at how to reduce the incidence of bad outcome, of potential harm, to get it to 0. Where we're taking those processes and those ideas and transforming them into healthcare. We call it the road to high reliability. And it goes to 2 specific principles. One is being preoccupied with failure. That means that we talk about failure all the time. I can tell you we didn't talk about failure all the time before we started this. We talk about failure in terms of what has happened in our hospital, in terms of safety and quality, and what can we do to prevent it? And how can we continue to look forward in that work? And then we have a sensitivity to operations. That means that what is happening at the bedside? How can we work with our caregivers, our nurses and physicians? What do they need in terms of a toolkit to improve our reliability in what we do every day? The programs that we put in place are the ones you see on the slide. They include having what we call a daily operational brief, rounding to influence, and a leadership series as the first 3 main mechanisms. First, daily operational brief. It's a simple idea, but it's pretty profound. It's a time every day that we as clinical leaders and operational leaders get together and talk about what's happening in the hospital. I lead it when I'm there. And we try to keep it at between 15 minutes to 30 minutes. 15 minutes is sort of the goal. But each area presents what's happening in their area, and they talk about their safety concerns. It's been a profound change for our organization because communication is one of the key components that we need to continue to push forward. And that allows us to communicate. We hear about problems. And in hear about problems, we can solve them. I'll give you an example. We had a problem actually with one of what we call a chair bed that we have in each of our patient rooms. We like and we want our families to stay with their child during their hospital stay, and that's what the mechanism we utilize. Well, one day, one of our nurse managers noticed that when a mom sat on the edge of the chair bed flew up and impaled her. A piece of it impaled her arm. So was that an isolated incident, or was this something we need to worry about? So she presented that at the daily operational brief. We immediately put a team together to look at all of our chair beds. Turns out that each one of them would do the same thing. We called the manufacturer and said, hey, what's going on here? We worked with them. There was a fix. There was an easy fix to fix this problem. Manufacturer comes in, works with us, fixes all our chair beds, takes us 6 weeks. I would tell you it probably would have taken us 2 years otherwise. But with this process, it took us 6 weeks, and we've notified the other children's hospitals, and the manufacturer has notified the other children's hospitals, there's a problem, and here's how to fix it. So that's the power of the daily operational brief. Rounding the influence. You know, we round, meaning that we go to where it's what's happening in terms of clinical care all the time. We call them howdy rounds. How are you doing rounds? We meet with our staff, talk about what their day is like, introduce ourselves, try to get to know them. This is not that kind of round. Rounding influence is very specific. We go and on a regular basis, at least twice a month, round in specific areas of the hospital and ask specific questions around safety and try to understand if our staff understands what they should be doing around this safety issue. If they don't, we try to educate. We educate them. And we also get feedback about the other safety concerns. An example of that is that I recently rounded and asked the question, if you have a problem, do you know how to escalate it? What's the process for you to do that? Who do you talk to and how do you present? I was told, you know, yes, we know how to do that, we're comfortable with it. But in many organizations, most organizations, there's a power dynamic. There's a fear factor. You know, can I really express, if I have a concern, can I really express that to someone? And how do I do that? And so we talked through that. And I gave them recommendations and examples of how to really work through that problem. That's an example of rounding influence. We also have a leadership series where we're educating all of our leaders around high reliability, expecting that to then cascade to our staff, with our goal to educate 16,000 people, 16,000 individuals around high reliability, to give them a toolkit to become highly reliable. The ideas are simple. Being committed to speak up for safety, a commitment to communicate clearly, and to pay attention to detail. Here's an example of that. This is an example of paying attention to detail, being committed to speak up for safety by asking a clarifying question. Tara is a nurse in our heart center. She works in the pre-op area. That's where the area before you go for an operation. Her job is to make sure that all the paperwork's there, the patient's examined and set up for an operation. In our hospital, we had a set of twins, twin A and twin B. One twin was scheduled to undergo a congenital heart disease operation. Tara had a concern. When she looked at the paperwork, she thought the wrong twin was scheduled for the operation. So she called the NICU and asked a clarifying question. Was this the correct twin? She was told, no problem, yeah, everything's taken care of, no worry. She continued to have a worry, so she asked another clarifying question to another group. In doing that, she found out the wrong twin had been scheduled for the operation. She also found out the twin that was scheduled for the operation was about to be fed, which meant we were going to have to cancel the operation for the twin who needed the operation. By doing that, Tara basically saved the day. The right twin had the operation at the right time. So that's an idea. That's the process. That's the concept of asking a clarifying question by paying attention to detail and speaking up for safety. So the idea of high reliability is not to add more work, but it's to take the work that we do every day and make it streamlined, make it efficient, make it relevant for those that are taking care at the bedside and taking care of our patients and families. As I mentioned, our goal is to get to zero harm. We're on that journey, and we may never get there in terms of that slide being blank. But our expectation is that we will make a significant impact for our patients and families around harm. The other example I want to talk about in terms of how we're embedding safety and quality into the institution, in terms of how we think about all that we do, is around our buildings, what we're doing, and I'm calling it innovative operations. We took the opportunity in the past year and a half to look at our facilities, our buildings, and found out that many of our buildings are pretty old. The clinical buildings are greater than 25 years of age for the most part. Some are 40 years, some are 100 years of age. In our environment, that's just not going to be able to stand because of the changes in technology, what goes into those rooms, what needs to go into our clinical rooms, and the regulations from the state and the federal government. And so we've realized that we've got to build new buildings, build new clinical buildings. And so that's an opportunity for us. It's an opportunity for us to really bring safety and quality to the forefront in that planning design. So we're going to build a new clinical building. We're calling it the Boston Children's Clinical Building on our Longwood campus. I hate calling it the Boston Children's Clinical Building. If you have $50 million, up to $100 million, you can name it. Okay. As of right now, we'll call it the Boston Children's Clinical Building. It's going to be on the, this is where you can see, if you've ever been to our campus, you know that that's the Harvard quadrangle there. There's a building missing, that's Harvard's, that blocks the whole, our building design. But if you took that building away, if you when you graduate at the Harvard Medical School, you would see our new building. This building, this new children's hospital, our new extension of the children's hospital, is very exciting. And at the forefront of our design thinking is around patient safety and quality. The idea of we have the opportunity to build a new kind of and construct a new kind of room that we're calling a acuity adaptable room. Based on the patient's acuity and complexity, the room changes because of the technology in the room, the equipment in the room, and how it's laid out. There's an opportunity for us to really design that. We're thinking about a streamlined layout of the building, the efficiency around the nurse taking care of the patient, how they interact with the doctor, the equipment that the nurse needs, the physician needs, and laying it out so that it really works for our patients and families from a safety and quality standpoint. We're also planning to place our pediatric heart center in the building. Currently, our heart center is in several buildings. It's actually one of the best, it is the best in the world. We do over 900 operations, pediatric operations. The average pediatric heart center, congenital heart operative program does about 300, 400. But our program is in several buildings. So what's the consequence of that? Well, the consequence of that is that if a patient has something like a arrhythmia and has a pacemaker, and there needs to be a plan or a process to take the pacemaker out, there's a concern that when you take it out, there could be a lot of bleeding, and the patient may have to go to the operating room. So in our current environment, our cath labs are in one building where this procedure is going to happen. And what has to happen is that the OR team needs to be on standby. They actually stand in the room. Because if something untoward happens, that the patient has to go to the operating room, they have to take the patient, go up 2 sets of elevators to another building for the operation. Now, we're really good at that, but that's not the way it should work from a quality and safety standpoint. And what we're going to build is a building that has everything on one floor. So the cath lab is on the same floor as the operating room, 50 feet away. So you can imagine the improvement in efficiency, in safety and quality that we're going to put into the building as a baseline. A lot of excitement around it, and that's where we're headed. So that's building design. Another part of what we do every day, of course, is our interaction with our patients and families. Access to us is profoundly important. And the title of this is Taking on Our Weakness. I will tell you that Boston Children's Hospital, as you know, is one of the best in the country, best in the world in terms of pediatric care. But at times, it's kind of difficult to get to us, for patients and families to reach us. We have moms, we have families, specifically the mom who does most of the arrangements to get clinic appointments done. We have moms who are experts. Their child has issues that result in them having to be seen by multiple physicians, subspecialists. We have a few moms that their child is being seen by 20 subspecialists. They make all the appointments in our current system. Can you imagine that? They have to navigate through all of our systems. Well, we're going to get rid of that. We're working to get rid of that. So that means that we're actually listening to our patients and families. And that's a safety and quality aspect that we are really embracing, the idea of family-centered care. So how are we doing that? We're doing that by, one, putting in new programs, new processes. One is one we call the Practice Liaison Program, where we're taking the burden of scheduling away from the family, and we're doing the scheduling for these our complex kids. This sort of started in 2006, but you can see it's been really turbocharged since 2013, when we are embracing the high reliability and really the idea around patient-centeredness, family-centeredness, patient care-centeredness, where it's important for us to really work with our patients and families to provide the access that they need at the time that they need it. With this, you can see the number of appointments that are being made by our liaison program. We expect that at some point, over 90% of our appointments are going to be made by us, taking that burden off the family, making it more efficient, making sure that our families, our patients get to us when they need to get to us from a safety and quality standpoint. We're also dedicated to listening to our families, asking them how their experience was. What do we need to change? What are the issues around the care that they receive for us, and how can we improve? Another aspect of quality and safety that we're embracing. We're doing that by actually partnering with the national group that does this, Press Ganey. Press Ganey does this it's a corporation that does this in many healthcare areas. We send surveys out asking our families simple questions, how was it? Would you recommend us again? Also giving them the opportunity to comment. Tell us, how your experience was. Give us advice about how we can improve. So we're taking that on, and we're able to benchmark ourselves to others in the pediatric space, others in the larger healthcare space, asking how are we doing, how compared to others, and how can we improve. This slide just really details the dashboard that we're creating, that everyone within our enterprise can get to, can see, and can utilize to help improve what we do every day. Just looking at the top, the patient experience. How do we judge that? The monthly change that we're going to see in terms of the amount of surveys we get back and how we analyze it. It's two simple questions. Our overall rating, how did we do? Likelihood to recommend, which is actually the key question. Would you recommend us again? Comparing to the benchmark, that's what we're asking across our hospital and enterprise. In our inpatient settings, our ambulatory settings, as two examples. Our outpatient lab as another example. Asking that question and getting feedback. Taking that feedback and changing our process and our program based upon that. It's exciting work, and we're at the I like to say, the first third of that work to really push that forward. So that's just a quick tour of what we're doing at Boston Children's Hospital in terms of quality and safety and where we're headed. It's a journey for us. We know that we're never going to complete that journey because the bar is always going to be raised in terms of what our expectations are of ourselves, our expectations from our patients and families, from safety and quality. But it's one that we're embracing and we're excited about. So thank you, and happy to take questions. Yes.
You talked about operational improvement. Are there specific methodologies and approaches that you enjoy relying on, find most effective?
Great question. What's sweeping the nation is the process around lean methodology. And healthcare is embracing that. I personally believe that's very important. It's a great opportunity. There have been a lot of failures associated with that in healthcare. Because in order for it to really work, you have to really understand what it means to have a management system. And that's not just doing a lean process improvement. It is how we think about things every day. How do you start your day? And that goes directly to high reliability. Those two are really integrated. The same verbiage, the same processes are utilized in both. So it's going to be our goal. It's our goal to really integrate those two as we move forward. There's a lot of opportunity at Boston Children's from that standpoint and bring lean methodology to us and creating our own, we're going to call it the Boston Children's Management System. But that's sort of where we're headed. Yes?
Thank you for your speak. Hi, I have a specific question about daily operation brief.
Yes.
I can imagine this is a great way to put the efficiency in the sort of process, but I can also imagine as the problem pile up, how can you balance this improvement program with the daily operation?
You've got to have the right people in the right position, the right positions and the right jobs to make sure that we can really tackle what we need to tackle. We're in pretty good shape at Boston Children's from that standpoint, and that we have a great structure of patient care services, great structure in terms of our facility work, great structure in terms of patient care services. We also have a tracking system that we've put in place. Problems identified, identifying who is going to deal with the problem, and then we come back at the daily operational brief at some point and talk about, has that problem been resolved? If it hasn't, what else needs to work? What else do we need to do to resolve that problem? It's worked so far, sort of keep the list down to a minimum in terms of what we're doing. It also involves, personally, me bringing it up. Saying, okay, guys, we're going to take the next 10 minutes and walk through the tracking to see where we are with these problems. Have we solved them? Why haven't we solved them? What do we need to do to get these problems solved? It's worked so far. I think we can continue to refine it, but that's where we're headed. Yes?
Thank you for a very stimulating talk. And for highlighting the critical role of patient safety. I think I read recently that medical errors are the third or fourth leading cause of death in this country. So I think anything we can do to mitigate that would be helpful. The question I have is, your organization, do you use tools like checklists, and how do you handle care coordination and transitions of care?
Yes, we do. There's still a lot of work in that space to really to understand what is necessary in terms of care coordination. And that goes to, care coordination is around really understanding what the patient needs, what services they need, and how they're coordinated to make sure that that patient gets those services, either in the hospital or outside the hospital. The more complex the patient is, the more that becomes important. But do we have the program and the people in place to make that work? If you have a patient who has, as I mentioned, mom has a child who has 20 problems, who should do the care coordination for that? Should it be the primary care physician who has another 10 kids or 20 kids waiting in the waiting room? Or should it be us? And if it's us, as Boston Children's, how do we coordinate with the primary care physician? Because that's where the medical home is, to make sure that it's working well, that everyone's communicating. We're right in the middle of that in terms of that work. And it's being driven by, in some respects, the federal government in terms of ACOs and et cetera. But that's the work that should happen as we move forward.
Hi. Understanding what's quality for consumers is a known problem in healthcare. I'd just like to know, what do you think about that issue? How can we help consumers understand what is quality healthcare? And then specifically, what are your thoughts about patient reviews, independent reviews on experience of service and quality?
Well, that's a great question. And that's one that we continue to try to get a good view on. And I've changed my mind multiple times on that one. From the standpoint that there's a great quote from Don Berwick, that from the standpoint of the patient, quality is giving me the health care that I want, that I need, when I need and want it. And every time I say that to physicians, they just start throwing things at me. Because, it goes, what do you mean? I should tell the patient, the family, what quality is, what they should be getting. And the idea is, where do we meet in the middle ground on this? So we can really move this ball forward, because that really means we're listening to the patient. Don Berwick's line is, how do we listen to patients to understand what their needs are, to understand what they want out of healthcare? And then how do we communicate that is really the important next step in terms of patient quality, their review, and our understanding of it. So that's sort of where we are. It's really a dynamic process, but it really goes to that patient-centeredness, that family-centeredness, and what we're trying to achieve. Your second question was about?
Patient reviews, but I think...
Yeah, and the patient reviews, we're trying to get that through the Press-Ganey work. It's more than just a survey. You know, the important one part of it is just check a box off, and that gives you information. But really, from a patient review standpoint, are the comments. They are incredibly rich. That families take the time to write back to us, to tell us about their experience, to give us ideas and recommendations about how we can improve it. And that's where we're really headed to change what we do. Yes.
Both a very interesting and moving snapshot of your journey at Boston Children's. You have shared a lot of change program components that are pretty congruent with each other, and you're moving forward with it. I wonder, and many other health systems and other organizations would appreciate doing that themselves as well. That's a difficulty. You're not presenting the difficulties in doing that. I wonder if you might, for them, share your lessons learned along the way, the hard lessons learned, the challenges you faced, and maybe you're still facing in being able to implement this in such a sustainable way.
Right. Yeah, you're describing, you know the challenges. The work is around getting everybody on board. The work is around getting everyone to see the importance of it and how it actually doesn't increase their work, but improves their work. The work is around educating everyone that there is a problem. Why would there be a problem at the #1 children's hospital in the nation around quality and safety? Don't you see we got the Leapfrog Award and U.S. News and World Report? Why are you telling me that there's an issue? Well, what I do is just show that one slide. You know, the snapshot of harm happens in our hospital. And it's because we're not paying attention. And we can change that. Some things you can't affect. Absolutely, you can't change. But there are some things we can. And if it's in our purview, how about we tackle it? That provides resonance. What also provides resonance is when a family stands up and talks about their experience. It's profound when they do that to our staff, to my colleagues. And in doing that, we've worked to really change the culture around that. Still got work to do. But you know what? I take every little victory as a positive step. I had a strong clinician the other day walk up to me and said, you know, Kevin, a year ago I thought this was a bunch of malarkey. But I have changed my mind. This is important. This makes sense, and I'm all in. And, it's sort of taking those little steps to move things forward. Yes?
Churchwell, thank you so very much. One of my questions actually goes around leadership, especially in Boston Children's Hospital, where it attracts so much like top leaders and top educated leaders. It becomes very difficult to manage these very high types of teams, so it's like herding cats. So what are some of the things that you, or mindsets, skill sets, or types of personalities that you would get on board to help orchestrate this big huge institution? And what can you say to other institutions that put Boston Children's Hospital on that?
That's an easy question. I don't know. The underlying goal or the underlying view of everyone that works at Boston Children's is the idea that they want to help children. So if you can bring it back to that goal, to that view, it becomes easier. It sort of works through the ego. It works through, opinion, et cetera. Are we achieving our goal by improving the lives of children? And then offering the data. Everyone wants the data. And you can argue back and forth, but ultimately you get to the data that shows we've got an issue that we can confront. And then saying, you know, it's our issue, let's solve it. You solve it. I'm going to work with you to help you solve it, as opposed to I'm going to solve it, I'm going to tell you what to do. That doesn't go well. But if they're engaged in it, if they're leading the effort, it makes all the difference. And then you go around and say, listen, guys, you know, it's all about Apollo 13. Failure is not an option. We have to do this. And to get the group, to get some incredible individuals to rally around that is what we work to do.
All right, thank you. We're actually out of time for questions, so thank you so much. You're welcome.
Thank you.